Yeah. Good morning, everyone. So far, we heard hyperfractionated radiotherapy, de-escalation of surgery, de-escalation of chemotherapy, and now I'm going to talk about sort of de-escalation of anti-HER2 therapy. We all talk about this to come into some consensus to work out in our SARC region. Right. I don't have any disclosures. So I will first go through the common HER2 breast cancer and then go through some trials which had compared different duration of anti-HER2 therapy. This HER2 positive breast cancer accounts for about 20% of invasive breast carcinoma. And we all know they are very aggressive and have a poor prognosis, but it can be offset by proper anti-HER2 therapy. By doing that, the prognosis can be almost similar to HER2 negative breast cancer. So if you just go through the history of HER2 receptors, which were discovered in 1984, and first anti-HER2 therapy, which was trastuzumab, was approved in 1998 for metastatic breast carcinoma. And in 2006, it was approved for adjuvant therapy. So this is the roadmap which I've just shown here, how we started trastuzumab, first for metastatic and then for adjuvant likewise with pertuzumab and so on. I'm not going to go in deep because my aim is to talk about how to optimize the therapy. Right. This is a current practice in ESMO. Now, if you just see here, remember now this at presentation, this is HER2 positive early breast cancer. At presentation, patient did not have any nodes. So we go for upfront surgery with radiotherapy, and then if still patient had N0, we still, because it's HER2, we still go for 12 weeks of paclitaxel and 1 year trastuzumab. Then if it is T2 and M0, there is no metastasis, so we then go for 6 to 8 cycles of chemotherapy with trastuzumab. And after chemotherapy, we still go for 12 months of trastuzumab. Then if after surgery the nodes were positive, 6 to 8 cycles of chemotherapy, then we incorporate pertuzumab into trastuzumab. So that also both will be given for 1 year. That is because the N was positive. So patients, early breast cancer patients coming with node positivity, upfront we give neoadjuvant chemotherapy, 6 to 8 cycles of chemotherapy with trastuzumab incorporated with pertuzumab, and then go for surgery. And if the patient has achieved pathological complete remission with no nodes, yes, we still go for 1 year of trastuzumab. And then if the patient had N plus at presentation, we still continue trastuzumab and pertuzumab for 1 year. And this green thing, after surgery, patient did not achieve pathological complete remission. So that's where we go to add TDMI. I think we heard good lecture today. So why I just do this is now see 1 year, 1 year, 1 year, and even more than that of anti-HER2 therapy. This is a bit cluttered, sorry about it, slide. That is, I will go through certain trials. Now, why is it 1 year? Who said to give for 1 year? So, we know first the HERA trial. It compared trastuzumab for 2 years versus 1 year versus no adjuvant therapy. Then it showed benefit in 1 year and 2 years against no adjuvant treatment. If you sub-analyze 1 year and 2 years, there was no difference. So they came to a conclusion. Yes, it is 1 year of anti-HER2 therapy. Then this trial, FINHER trial, what I said is here. So before going to that, so 1 year of adjuvant became the standard of care because of HERA trial. So FINHER trial further investigated the 9 weeks of trastuzumab first given fake chemotherapy, then docetaxel with trastuzumab versus effect last docetaxel without trastuzumab, and also they compared, instead of docetaxel, they incorporated vinorelbine as well. So the trials, the results said adjuvant trastuzumab administered even for a short time, that was for 9 weeks period, concomitantly with docetaxel, improves efficacy compared with docetaxel alone. And another thing came out, the docetaxel gave significantly better outcome than vinorelbine. And overall, this 9 week of anti-HER2 therapy gave very less cardiac toxicity compared to 1 year. So I told now, those two trials did not compare two durations of anti-HER2 therapy. So this is the area I'm going to talk about. These two have compared anti-HER2 therapy adjuvant for early breast cancer, 9 weeks versus 1 year, and these three compared 6 months versus 1 year. Short trial, as you see, there's short term and long arm. So in the short term, I'll just take first short term 3 cycles of docetaxel with weekly trastuzumab followed by fake. And then on the long arm, 4 cycles of ACO-EC followed by 4 cycles of Taxol. With the first Taxol, they started a trastuzumab, which went on for 1 year. Right, this is what I said. So short trial, ultimately, they did not show any non-inferiority. But researchers, because of this trial, they were still wondering, is there any possibility that we can think of some subcategory where we can give shorter duration? The SOL trial also, 3 cycles of docetaxel followed by FEC, and then continued for 1 year in the long arm. Still, this also did not show significant, did not give any non-inferiority data. So these 2 trials were not non-inferior to 1 year. Then FAIR trial, short term 6 months, and then long arm 12 months adjuvant after 4 cycles of trastuzumab. Then that trial also did not show non-inferiority. This is a FAIR trial. So 4 cycles of this thing, that is 6 months, and then other one is for 12 months. So not non-inferior. Whole trial, adjuvant 6 months was 1 year, also did not show non-inferiority. This is the only trial which had over 4,000 patients. First one trial showed significant difference of disease-free survival and also overall survival in 6 months compared to difference in the sense non-inferior. Non-inferiority was demonstrated in this trial. And also on top of that, it showed significant reduction of cardiotoxicity in 6 months. This is the schema. Right. So I'll just come to this. Now, earlier, I think John also spoke about the cost saving. Here, the 6 months of trastuzumab saved nearly 10,000 of pounds in UK. So it's very much cost effective. And they say they have calculated the main savings in breast cancer treatment is from trastuzumab and administration cost, because other things, cardiac assessment, other things do not cost as much as trastuzumab. So, as I said, they're more economical in 6 months trial, 6 months arm, and but we have to remember one thing: this subgroup analysis of this trial still could not exclude the benefit of 1 year of trastuzumab. So still 1 year remains the standard of care, standard duration in anti-HER2 therapy. So these are in nutshell. This is the only one which showed non-inferiority. So we are talking about optimization. Why should we optimize? Should we? Yes, we should. Why? Now, we are talking about that to get the benefit of trastuzumab, but we are in a region where even we don't have the accessibility to basic chemotherapy drugs. So we need to find a compromise. So why do we, as I said, for accessibility, disparity between the countries and also in one country between urban and rural regions. And toxicity plays a major role. And if somebody is on 1 year anti-HER2 therapy, the 2D echocardiogram is very costly and not accessible for everyone here. Most of the patients, it's not available. And the mortality to incidence ratio in SAARC countries is high. So we need to first address the basic things than going into with high-end treatment modalities. So contributor factors for optimization is a financial burden for the government, patient, and cardiotoxicity, as I said, doing 2D and other investigations, transport issues, and long stay outside the hometowns, which make them pay for food and lodging. And also, most of these patients are getting a daily income, so they miss work, so that also again affects their financial situation. And emotional toxicity, also poor infrastructure, as already being mentioned. How to optimize? Yeah, we have to always think about balancing efficacy and cardiotoxicity. For many patients, with node negative and ER positive, shorter duration trastuzumab would likely be sufficient. And if they have cardiac or other comorbidities, this may be even safer than 12 months. And we request, we should come to some consensus to consider short duration trastuzumab when appropriate, at least for HR positive and N0 disease. And most clinicians say now, if in 12 months regime, the disease-free survival is 89.8, but it will come to 83 with 6 months. Even that is all right, because now they say because when you consider cardiotoxicity, this still can be acceptable. Sorry, and you can use biosimilars also. Biosimilars are also expensive these days, but still, there's a possibility that if affordable, go for biosimilars. Challenges, as I said, infrastructure challenges and skilled healthcare professional shortage and economic constraints and low involvement of clinical trials. So in summary, so as I said, adjuvant anti-HER2 therapy remains the gold standard in early breast cancer, and still 12 months regimen seems to be the standard of care, and but it is it gives more frequent and severe cardiotoxicities. And out of 5 trials, only first 4 trial gave non-inferiority for 6 months against 12 months. And if N0 and ER positive try, we should come to consensus. Whenever there's a possibility, go for shorter duration, and it may be a safer option when patients have heart diseases or had received earlier cardiotoxic chemotherapy and in low-income countries. Thank you.